soon. So this is the first case I want to present before you. This I have named it as Unveiling the Mystery. Like any great mystery, this case began with unanswered questions. A patient with persistent keratitis, multiple treatments, yet no resolution. And let's follow the clues. Just like in this scene from Loka, where the truth lies hidden under the layers of suspense, our case too began with unanswered questions. The cornea showed only subtle signs, nothing dramatic, nothing classical. Routine diagnosis failed, and every clue seemed to mislead us. But beneath that opacity, there was a deeper story waiting to be uncovered. A story we could see only when we started looking beyond the obvious. Our objective was to highlight the importance of keeping an open mind when a post-keratoplasty infection doesn't behave as expected. This was a 72-year-old female with redness, pain, and defective vision in a grafted eye, unresponsive to cocktail treatment. And like in the movie Drishyam, like George Gutti piecing together clues from his favorite crime shows, our journey also began with curiosity, determined to solve a clinical puzzle that defied usual patterns. So this was the timeline of the patient. Both her eyes had undergone previous PKs with no useful vision. The left eye was the presenting eye. The left eye was status post 2 full thickness grafts with no useful vision, and she was on maintenance dose of topical steroids since many years. And this was the corneal condition which she had underwent, a corneal dystrophy that was present in her family. And 2 of her affected siblings had underwent keratoplasty for the same condition. On slit lamp evaluation, we saw a dense inferior stromal infiltrate with vascularization but no hypopion. It was not quite fitting fungal or bacterial keratitis that prompted us to re-evaluate the diagnosis. Sachin. So we considered the common pathologies, whether it is a bacterial, fungal, or viral, but none matched perfectly. The atypical picture and lack of response made us suspect something unusual. Each possibility looked convincing at first, whether it is a bacterial, fungal, or viral, but none fit the entire picture. So the bacterial we initially thought because she had gone to a nearby hospital and they have proven microbiology report, that is staphylococcus was present in the smear as well as the culture. But the lack of classical features aroused a suspicion of a rare pathogen. And like again George Gutti reviewing each step to eliminate errors, we re-examined every possibility. Repeat corneal scrapings were done and 1% AFP different stains were used. And finally it it showed oval refractal structures on gram stain consistent with microsporidia. And we confirmed this with an expert review, a real aha moment. And then under the microscope, the truth emerged. The culprit was microsporidia. And it was managed accordingly. The patient was given 1-week trial of topical voriconazole, but since there was no response, she was taken for a therapeutic keratoplasty. And the keratoplasty, the biopsy also with the pus stain, showed the same spores. And finally, the vision improved to 618. And it was a very boon for this one-eyed patient who was suffering from long-standing defective vision bilaterally. So, challenges and takeaways from this case are microsporidia can mimic bacterial or fungal keratitis, and it is very difficult to culture this organism. But with a high rise of suspicion and correct stains like 1% AFB, modified trichome, and calcoflow white, your diagnosis will be ready. And collaboration with the microbiology is essential for the diagnosis. PCR may be confirmatory. Topical fumagillin is effective against Microsporidia spores. Severe cases, you can add oral albendazole 400 milligram twice daily. We started initially with topical voriconazole. Some centers treat with chlorhexidine eye drops as well. But finally, the treatment of choice in stromal microsporidiosis is therapeutic keratoplasty. So how this case adds to the existing knowledge is microsporidial stromal keratitis may mimic bacterial or fungal, and collaboration is the key. In summary, persistent graft infection should raise suspicion of rare pathogens. Early recognition, proper stains and teamwork can truly unveil the mystery. Thus, and just as the film slowly unveils its secrets, this case reminded us that ophthalmology too demands patience, curiosity, and the courage to question what we think we already know. Thank you.